Well, good evening and welcome to you. I'm Chris May at the KATV studios in Little Rock, Arkansas. From wherever you are watching on the World Wide Web, we welcome you. This is the first in a series of webcasts focused on your health that KATV is producing in partnership with CHI St. Vincent, a regional health network serving Arkansas since 1888. A long time. I'm joined by Dr. Thomas Wallace, who is a cardiologist with CHI St. Vincent Heart Institute here in Little Rock. He specializes in cardiac electrophysiology. Doctor, good to be here with you. Thanks so much for taking time.
Thanks for having me.
It's going to be a fun half hour. Over this the time of this webcast, Dr. Wallace and I will discuss atrial fibrillation, which is better known as AFib. It's an arrhythmia that impacts more than 33 million people around the world, and left untreated, it can lead to stroke or even heart failure. With more on AFib, here is KATV's Aaron Hawley.
And folks, as they age, ages 60 or older, we're seeing it more and more and more. And it's caused by all kinds of issues, from obstructive sleep apnea to an overactive thyroid. Sometimes it's just a condition that the heart has as it ages.
The meds and the ablation have controlled my AFib. I don't have any issues when I exercise now. Quality of life is great.
With treatment, she's been able to get back to working out and encourages others with AFib symptoms to get checked.
I feel great. I feel really good. That's a gift.
Okay, that is Aaron Hawley reporting for us tonight, and we'll hear more from Aaron a little bit later in this half hour or so. We do want to invite any questions that you may have tonight about AFib. Just look in the comments section of this web stream. Type your questions in there. We've got a computer, and we will answer your questions just as soon as they come in. In the meantime, though, again, Dr. Wallace, thanks for coming. You have said that AFib is an epidemic. How so?
It is. So I would say the 1960s, the 1970s, physicians, healthcare providers really didn't understand the impact of atrial fibrillation. And over the course of the decades, we've become more intelligent in the way we take care of it, the way we diagnose it, and the way we treat it. And in this process, with an aging population, our baby boomers moving into an older age, we're seeing AFib more and more and more. The World Health Organization several years ago did declare it an epidemic. At least 5% of patients over the age of 70 will have at least one episode of atrial fibrillation. And the challenge with that is that atrial fibrillation in and of itself is not likely to kill you, but it certainly can have you develop heart failure. It can cause you to have a stroke. And there are many morbidities that go along with the presence of atrial fibrillation.
Yeah, particularly if it's left unchecked and
exactly.
untreated. So what causes atrial fibrillation, and who would you say is most at risk for it?
So the causes of atrial fibrillation are protein. Mainly, it's age. I will tell patients that I think of atrial fibrillation as usually a consequence of an aging heart. Like our skin wrinkles, our hair turns gray, and as our heart gets older, scar tissue may begin to set in, the chambers of the heart may get stiffer and less compliant, and the triggers of atrial fibrillation become more and more present. So really the number one cause, I would say, is age. But other things that contribute to it: high blood pressure, diabetes, valvular heart disease, an overactive thyroid, excessive alcohol intake, terrible sleep apnea, obesity. So we're beginning to understand that many different illnesses can drive the body and the heart into going into atrial fibrillation.
Right. Okay, so if it is, though, a manifestation of aging, it's much more likely to present in a 50-year-old than an 18-year-old.
Exactly,
obviously.
right.
Okay. When you look at the symptoms of AFib, and I think we have those that we can pop up on your screen right now. Let's take a look at them. Heart palpitations, strong awareness of your heart beating, weakness, fatigue, chest pain, pressure or discomfort, dizziness or lightheadedness, shortness of breath, anxiety. I mean, doctor, these are symptoms that you are just not going to miss if they pop up in the course of your day-to-day life, correct?
This is true. And everybody presents differently with atrial fibrillation. I would say that in a younger patient, we'll see them coming in complaining of a racing heart, like palpitations, fluttering, flipping and flopping in the chest, like a hummingbird's in the chest. They may have shortness of breath with it. As you age, we may see people complain of breathlessness or just fatigue. They have atrial fibrillation, and their heart rate may not get as fast as it needs to get when they walk up a flight of stairs or up a hill and they're short of breath. So chest pain sometimes we see, but usually we'll see chest pain if the patient is in atrial fibrillation with a really fast heart rate, and then chest pain will manifest.
I've got to think that if I ever experienced heart palpitations or being aware of my heartbeat, the first thought I'm going to have is I'm having a heart attack.
Yeah.
What's the difference between atrial fibrillation and having a heart
That's
attack?
a good question. The classic symptoms of a heart attack are a severe, heavy chest pressure in the middle of your chest that may or may not move to your shoulder or your arms, with breathlessness, maybe nausea and sweating, a sense of doom. You may look gray or ashen. Whereas someone with atrial fibrillation, they come in, their complaints are not so much that deep substernal chest pressure, heaviness, but rather a racing heart, a flipping, a flopping, and maybe breathlessness with that.
Okay. What's the first thing someone needs to do if they do start experiencing symptoms like the ones we're talking about here?
So, to distinguish, when you have that chest pain story that I described that goes along with a heart attack, that's a, let's call 911, let's go to the ER, this is serious, this could lead to sudden cardiac death. I mean, that's serious. If you're having the symptoms of atrial fibrillation, it's not that type of emergency. So, it's reasonable to call your physician. It's reasonable to call an ER or an urgent care center. It's reasonable to go to the emergency department, but the same level of urgency is not there.
But it is urgent to seek treatment because, again, as we said, left over time, they can lead to serious consequences, right? You want to talk about those?
Right. And so those consequences, if we have a patient who's been in atrial fibrillation for days and weeks, and they have other risk factors for a stroke, they need to be on blood thinners. And these blood thinners, the classic blood thinner that we know about is Coumadin or warfarin that's been around for decades. The newer blood thinners that we see advertised on television like Xarelto, Eliquis, and Pradaxa, those are the ones that are the newer ones that we use on a daily basis. The purpose of those blood thinners is to prevent clots from forming in the heart when the patient goes into atrial fibrillation. Because when the heart goes into AFib, the blood doesn't move as easily through the atrium or the top chamber of the heart, and the blood can pool, and when the blood pools, clots can form, and then those clots can move through the heart and go to the brain and cause a stroke. So putting patients on blood thinners prevents those clots from forming.
Yeah, and can save a life. We'll talk more about treatments as we go on. I have read that symptoms can actually disappear, but even if they do, the arrhythmia can still remain. That sounds kind of frightening.
Isn't it? Yeah, so then it's interesting. Usually a patient who is new to the diagnosis of atrial fibrillation or a younger patient will be very symptomatic. As the disease progresses and may be unchecked without being treated to stay out of AFib, we begin to see patients, especially in their 70s, 80s, and 90s, they get to the point where they're in atrial fibrillation all the time. Their heart doesn't race anymore, and they get to the point they don't feel it. Now, that's okay. I'm okay with that, provided that their heart rate's not too slow. They may need a pacemaker. Provided that their heart rate's not too fast, well, we need to slow it down with medicines. But most importantly, that they're on blood thinners to prevent that stroke.
Okay. What about risk factors for developing AFib? Who's most likely to get it?
Right. So the risk factors, we broadly divide atrial fibrillation management into two groups. Those who have valvular heart disease, that means that the mitral valve in the heart is not working well. Either it doesn't open and close well, or it's wide open and we get a lot of regurgitation through that valve. So valvular heart disease patients, those patients are at a risk of having AFib. The other group is non-valvular atrial fibrillation patients, patients who have normal heart valves. Those risk factors are patients who have high blood pressure or diabetes, obstructive sleep apnea, obesity, hypertension, an overactive thyroid, and alcohol abuse.
Well, and some of those things can be controlled.
Right.
Diabetes, alcohol use. If you're able to get a hold of those things, does that lessen your chance of having AFib?
Absolutely. There are two great clinical studies that have come out in recent years looking at the treatment of obstructive sleep apnea as a way to prevent the progression and even show some regression of atrial fibrillation burden in patients. So obstructive sleep apnea management is critical. To have a sleep study, be evaluated for obstructive sleep apnea, wear a CPAP mask if you need it. The other category, and it's the epidemic, it's the real epidemic in the United States, is obesity. Obesity drives all these diseases, and these diseases all come together. So obesity drives hypertension and diabetes and obstructive sleep apnea, as well as atrial fibrillation. And there are plenty of studies that show that if you lose weight, if you get down to your ideal body weight, your burden of atrial fibrillation goes down.
Well, okay, another great incentive there to lose weight. There are 3 different types of atrial fibrillation. Can you tell us about those?
So in terms of the timing or the chronicity of AFib, there's new onset AFib. We call it paroxysmal AFib. These are patients who go in and out of AFib briefly. They may be in it for hours at a time. Then we have those who have persistent atrial fibrillation. Those have been in it for more than a week at a time, or have had to be cardioverted or shocked out of that rhythm. And then we have a group called long-standing persistent atrial fibrillation. Those are patients who've been in atrial fibrillation continuously for over a year.
Okay. When you first tell a patient who presents to you that they have atrial fibrillation, what, that's got to be a frightening diagnosis to receive. What's that conversation like? What do you tell them right off the bat?
Well, first of all, I try to tell them that this is not a death sentence. This is not a heart attack. This is not, you're going to die tomorrow from this condition. I try to ease their mind a bit and let them know it's going to be okay. This is a disease that can be managed. I assess their risk for stroke in the setting of atrial fibrillation, and we make the decision what blood thinner to put them on. And then we try to sort out whether or not they're symptomatic from their AFib. If you've got patients who are highly symptomatic when they go into atrial fibrillation, they're calling the office, they're feeling their heart palpate, we like to put those patients on medicines to keep them out of AFib. And if those medicines don't work, we move quickly to doing one of these catheter ablation procedures to fix the problem.
Okay. We'll talk more in depth about treatments, but we are getting a lot of questions here. Leslie Stevenson writes in to say, my husband has a cardiac ablation and has been having spells lately, light headaches, racing heart, low blood pressure, then it all passes. Are those symptoms, she asks, of AFib?
The racing heart could be atrial fibrillation. It could be some other abnormal heart rhythm as well. So it's difficult to know without having that patient wear a heart monitor and to see if it's atrial fibrillation or if it's another rhythm.
Okay, but certainly something they should consult their doctor
Sure,
on, right?
absolutely.
Okay, so again, every situation is different, but it seems like there are 2 ways to treat AFib, with medications and with procedures. Let's talk a little bit more about the medications. You're talking about blood thinners, especially right off the bat. Talk about those, if you will.
So when I see a patient with atrial fibrillation, the first thing we do is make the assessment, do they need to be on a blood thinner, and if so, which one? And we do that. In fact, in all the clinical studies for patients who have atrial fibrillation, at present, the only real thing that we do that makes people live longer, that there's a mortality benefit to our intervention, is the blood thinner.
Something as simple as aspirin?
No.
Oh, not aspirin.
No.
Okay.
So aspirin is not, that's a good question. We put aspirin in that category for patients who have coronary artery disease, who've had blockages of their coronary arteries, who've had stents in the past or bypass surgery in the past. For patients with atrial fibrillation, it's a different type of blood thinner.
Okay.
And it's either Coumadin or warfarin. It could be Pradaxa, Eliquis, or Xarelto. Those are the 3 newer blood thinners. And we give those to patients to ensure that their blood's thin so that clots don't form in their heart.
Okay, and these medications, did they control the heart rate as well? Some medications do.
Right, so those are the blood thinners. The next medicine that they go on is a medicine to control their heart rate if they need it. So those are medicines called beta blockers or calcium channel blockers. And these medicines are like putting the brakes on a racing heart. And so we choose that medicine, titrate it to effect so that we keep their heart rate leniently between about 60 and 100 beats a minute. Okay. And that's our goal.
Getting those dosages just right, I imagine, is a challenge, is it not?
Yeah, it can be. You you start at either low or medium dose and just titrate to effect. So if the patient is having a challenge, their heart rates are still fast despite a reasonable dose, they'll call the office and we'll say, okay, go up to this dose. And then the other medicine, there's another category of medicines for atrial fibrillation that are designed specifically to keep the patient out of AFib. So the beta blockers and the calcium channel blockers are to keep the heart from racing when they're in AFib. The other category of medicines are designed to keep the heart out of AFib. And those are called anti-arrhythmic medicines. There's about 6 on the market that we use, and they're selective. We have to pick the right one based on the patient's kidney function, age, existing heart disease, liver function. And so we make that decision, give that to the patient, and see if that medicine works at keeping them in normal rhythm.
Okay. We know that there are some folks out there who can't tolerate blood thinners. And for those folks, there is something called the Watchman. And we're going to talk about the Watchman in just a moment. But first, let's go back to our Erin Hawley. She has a closer look at this device that is out there saving lives.
Presence of Amazon in this area, or any development like that, is a good thing.
Like anything to potentially create more jobs for people. And the economy's been hard.
I have no problem with Amazon.
The Seattle-based tech giant intends.
That was the wrong tape, but we can talk more about the Watchman. It's an implantable device. Tell us about it and the impact that it has on the body.
So there are patients who need to be on blood thinners to prevent strokes from happening, but can't take them for whatever reason. Bleeding, GI bleeding, having blood in their urine, having a bleeding condition overall. They're a high fall risk, so that we worry that they'll fall and hit their head and bleed into their head. So for those patients, what we do is address an area in the heart called the left atrial appendage. And this is a small region that comes off the left atrium. It's about the size of your two fingers. Mm-hmm. Blood can go into that region, and that's where the clots mainly form in patients who have atrial fibrillation. So if you can remove that appendage from the left atrium, functionally, those clots can't form. So there's several ways of doing it. You can have open heart surgery, and the surgeon can cut the appendage off and sew it closed. You can have open heart surgery, and they can put a clamp around that appendage and clamp it closed. Or we can go on the inside of the heart over into the left atrium and plug that appendage closed so that blood can't go in there. Mm-hmm. That's left atrial appendage occlusion therapy, and one of those choices is the Watchman device.
Mm-hmm. And the Watchman is implanted directly in the heart?
Right, right.
Do you feel it? Do you know it's there after it's, okay?
In fact, if you do, that's a problem.
Oh, right, okay, right, exactly. But it is it's a simple process. It doesn't require a long hospital stay, correct?
No, it's about a 45-minute procedure. You come to the hospital, we put you under general anesthesia, so you're unaware of what's happening, and we put a small catheter through the vein in your leg and direct that catheter up into the heart. We go over to the left side of the heart, and we deploy this little device that looks kind of like a parachute or an umbrella. It's in the closed position. We put it into the appendage, and then we unsheath it into an open position, and it, in essence, wedges itself into the appendage and closes it.
And I understand CHI St. Vincent was one of the first to use the Watchman in Arkansas. So it's an effective choice for people who are dealing with AFib.
And then those patients don't have to take blood thinners in the future.
Right.
Those are the happiest patients.
I bet. Are blood thinners the preferred solution for you as a doctor? The Watchman, what would you prefer to do?
So right now, compared head to head, the Watchman device to Coumadin, they're equally effective at preventing strokes. So when I look at a patient, if they're tolerating Coumadin or warfarin or another blood thinner, and they're not having any bleeding issues, and they can afford the medicine, and they're not having any side effects, I just leave them on that medicine. Mm-hmm. But if they have issues with these blood thinners, then the Watchman is an excellent alternative.
Okay. Let's try to see if we can pick up a few questions coming in from our viewers. Let's see. What is Dr. Wallace's opinion on the link between AFib and, I'm going to let you pronounce that because you probably know it better than me. This is from Mandy Hodges, but she's asking
Mandy
about...
writes, what is my opinion on the link between atrial fibrillation and a condition called Takotsubo's cardiomyopathy? Takotsubo's is a Japanese word that means octopus.
Okay.
And there are patients who have what are called stress-induced cardiomyopathies, where the heart suddenly expands and dilates. And on X-ray or an ultrasound, it actually looks like the head of an octopus. It's big and baggy and doesn't beat well. Now, those patients with that condition over time may develop atrial fibrillation as a consequence. Mm-hmm. So it is not surprising that someone with a cardiomyopathy would ultimately develop atrial fibrillation.
Okay. Thomas asking, well, that question just went away, actually. So let me ask you a question that I have here. In terms of procedures, there's also an electrical cardioversion.
Right.
What exactly is that, and how does it benefit the patient?
Right. So the term cardioversion means to reset the heart from atrial fibrillation back into normal rhythm. Mm-hmm. And there are three ways of doing it. You can chemically cardiovert somebody with a medicine. Just give them medicine, wait for it to take effect, and it may make the heart transition from AFib back into normal rhythm. Mm-hmm. You can electrically cardiovert somebody by bringing them to the hospital, sedating them, putting the pads on their chest, and delivering a small amount of energy between those pads sits the heart. The whole heart just contracts at once, and then as it relaxes, it comes back into the normal rhythm.
Okay.
And then the third way to cardiovert somebody is to ablate them, which is like the catheter ablation procedure to get them out of AFib.
Okay. Once you get that heart rhythm back to normal, is that it? Is the person done?
I would
No.
say, I tell patients it's like an old PC computer that's giving you fits. You know, what do? You turn it off, you turn it back on, and it'll work. It may work for a while, it may not work for a while.
Right.
The glitch may come back.
Are there advantages from a catheter ablation compared to a thoracoscopic ablation?
Well, that's a good question.
Thank you very much. I tried to do my homework coming into this.
That is some homework right there. So right now, conventional therapy for atrial fibrillation ablation is a catheter-based procedure, which is done by putting catheters into the heart. We actually enter into the heart through the right atrium. We're working within the left atrium, and we're ablating the regions that are the sources of AFib. A thoracoscopic surgical atrial fibrillation ablation is an epicardial approach. This is our heart surgeons putting ports in the chest, going into the pericardial space, exposing the heart from the outside, using scopes to visualize it, and clamping the regions that are the sources of AFib. And with these clamps, they can heat those clamps, and it actually creates lesions within the heart that fix the AFib.
Wow, it's incredible. It's incredible work you do. Are there risks associated with these kind of ablations?
Yes. Now, the risk of an atrial fibrillation ablation is low, but I'll tell patients it's low but not zero. There's about a 1% chance of a major complication happening. Now, these risks include bleeding and infection. There's a very small risk of stroke with the procedure. There's a very small risk of bleeding around the heart with the procedure, and occasionally those patients need to go to the operating room to get it fixed. The risk of a surgical atrial fibrillation ablation, like the thoracoscopic approach, there's a risk of infection, inflammation around the heart, damage to the heart itself.
And those procedures usually require longer hospital stays as well?
They may, yeah.
Okay. Peggy asks, my husband is on 2 beta blockers after having 2 ablations. Will he always have to take these, and does he need to be on a blood thinner?
It's hard to answer that question without really knowing the specifics.
Yeah.
I would say that we have a scoring system that ranks which patients should be on a blood thinner indefinitely and which patients don't need to be on a blood thinner. Usually if patients have had ablations, they need to be on blood thinners indefinitely. To the question about the 2 beta blockers, I don't know that I can really answer that without knowing the details.
Okay. One question here, something about ATEC. Then the question just went away, but something about, well, what is ATEC? Tell us about that.
So an atrial tachycardia is a cousin to atrial fibrillation.
Okay.
So atrial fibrillation really is a chaotic, abnormal electrical rhythm that comes from the top chamber of the heart. Mm-hmm. Atrial tachycardia is a more organized abnormal rhythm where there's a single focus in the atrium that's making the heart beat quickly.
Okay. Let me see if I can try to pull up these questions just a little more. Yeah, there it is. Well, what is ATEC, and do I have to be on a beta blocker? I think that's the other question, part of that question. Do you have to be on a beta blocker when you're dealing with ATEC?
So atrial tachycardia, by definition, means a fast heart rate that's arising from the atrium. It may be 100 beats a minute, it may be 150 beats a minute. We usually will give medicines to slow the heart rate down if someone's in an atrial tachycardia. It may be a beta blocker, or it may be a calcium channel blocker, or another medicine.
Okay. If someone has AFib and they don't have it treated, how's that likely to end?
It's a good question, because I will see as many patients with a new diagnosis of atrial fibrillation who are having all these symptoms and they're coming to our office asking for help. I will see the same number of patients who have just incidentally been found to have atrial fibrillation when they're going in for their colonoscopy or some other an ophthalmologic procedure. It's an incidental finding. So if those patients may have had atrial fibrillation for years, they're doing just fine. Their heart rates are not that fast, because if their heart rates are fast, they'd probably have called us. So there are plenty of patients walking around, mainly in their 70s and 80s, who have chronic atrial fibrillation and have no awareness. They're not symptomatic from it, their heart's not racing from it. And for those patients, we really leave them alone, just make sure they're on a blood thinner.
Wow, incredible. You've been doing this a long time. What kind of advancements have you seen in the treatment of atrial fibrillation that still excites you today?
Oh, this field is, what I love about this field is it continues to be on the upward slope of technology and development. The treatment for atrial fibrillation with catheter-based approaches that we talked about earlier is really where it's moving. We have seen a transition from treating everybody with just good old-fashioned heart rate slowing medicines in the 1980s to the 1990s, heart rhythm medicines to keep them in normal rhythm, and now we're seeing just the blossoming of catheter ablation techniques to fix people with atrial fibrillation. Where is it going in the future? Even this week, there is an article in one of our academic journals talking about direct proton beam radiation to the areas in the heart that would fix the areas that cause AFib without any catheters in the heart.
Oh, incredible.
Yeah, it really is.
Yeah,
it's
unbelievable. If someone needs more information, if they have questions that they want answered, what would you recommend they do?
Oh,
Besides watch web streams like ours.
Well, you usually start with your primary care physician.
Okay.
And then patients will go and say, I'm having atrial fibrillation. And the primary care physicians do an excellent job talking about those modifiable risk factors like hypertension and diabetes and obesity. If they put them on medicines to slow the heart, if they're still having problems, then call the cardiologist.
Okay. Call Dr. Tom Wallace. Thanks so much for being here
thank
with
you.
us.
Yeah.
Enjoyed our conversation,
Yeah,
and
good.
we hope that we have helped share some important information with our
thank
viewers
you.
out there.
It's
Great to
been
be
fun.
with you. Dr. Thomas Wallace, cardiologist with the CHI St. Vincent Heart Institute in Little Rock. Again, it's been a pleasure. If you miss any part of tonight's web stream, you can catch it anytime right here on the KATV Facebook page. Thanks for being with us. Good night.